everyone. Thanks for joining today. Uh, we're going to talk about what to expect during and after a memory evaluation. I have found that as a memory specialist physician, often families, by the time they get to me, they've often been through quite an ordeal in a system that's very confusing and complicated and often very frustrated. Now, I'm glad they got to me and often wish they would have gotten to me sooner. But I know there are many out there that either never pursue an evaluation because of all the barriers or start and maybe stop prematurely before they get all the information to really help them. So please share this information, ask your questions, reach out to me during and after this for yourself or your loved ones or patients and families, so we can really get the knowledge and support that we need. All right. So, what we're going to go over today is to understand and demystify the memory evaluation process. It really is multiple steps and usually multiple visits, and maybe with more than one provider. I think there's a misunderstanding that it might be one visit, you figure it all out, but that is not the case. And then know what the results mean and possible next steps. So this is really focused on that process of getting to determine what is going on, what are the causes, and the immediate next steps. There are many reasons people reach out for a memory evaluation. That could be they are noticing some changes and they want to know if it's normal aging versus not normal aging. People who have a family history of any kind of dementia typically get in sooner and are younger when they reach out for information. And that makes sense because they've often had a parent who has gone through that and they've been a care partner. Maybe they don't think they have Alzheimer's, but they want to see if there are some kind of reversible causes for what's going on. Family and caregiver concerns is a common reason that people seek out a memory evaluation, especially as we're getting older. It's often the family members that end up um, pushing that issue. And then wanting more information on early detection, diagnosis, and treatment. And so, why is that valuable? Knowledge is power. This helps you take control of what's going on, whatever it is. Then you can know your options, decrease anxiety about the unknown. This anxiety about what's going on is pervasive. And we talked about in the Alzheimer's versus dementia talk some of the reasons that people don't pursue diagnosis. And often, though, when they do ultimately get that information, they're relieved. But it is a process to get to that point to feel comfortable reaching out. Then people want to find out what are the potential contributors, are there medication options? Some people are aware that there's more medication options now, specifically for Alzheimer's disease, when you start getting sooner, earlier on in terms of the disease, and then getting connected to care support and resources. Just to review, this we talked about last time. What are the warning signs that it's time or it's overdue to get a memory evaluation? So I divide this into yellow flags versus red flags. And my rule that I've come up with is if you have 3 yellow flags or 1 red flag, it's time to get in. So frequent and slowly worsening forgetfulness, repeating information, difficulty following conversations, trouble with daily tasks, misplacing items frequently, language difficulties, challenges with problem solving, and then feedback from family, friends, or coworkers. So I say if you or someone you love has 3 of these going on, then definitely it's time to pursue that evaluation. Shifting to the red flags, these are the major safety issues. I recommend if there's one of these present, it's necessary to get checked out. So we have medication errors, falls, wandering, cooking accidents, impulsive or risky behavior, potential for self-harm or harm to others, and driving hazards, and then exposure to environmental danger like fires. So 3 yellow flags or 1 red flag, get in with your healthcare provider. Now, I say get in like it's so easy, but actually, we know it can take a long time. It can take quite a long time once you reach out to your healthcare provider to get a diagnosis and treatment, and particularly if you see a specialist. So we can see the box on the right. We have from the timing of symptoms and reaching out for an appointment with your primary care provider to treatment. I estimate that it can take 1.5 to 5 months to start getting treatment and connected to care and support and resources. And that's probably an optimistic estimate, frankly. Now, I just want to mention, though, before the pursuing of the appointment, the scheduling the appointment, there is the recognizing the symptoms, which can take up to several years. And I've seen up to 8 or more years for that. And then the next step would be scheduling that appointment with a primary care provider. So that can take a couple months to get in to see them, discuss the concerns. And I'll go through all of these in subsequent slides in much more detail. Then they would pursue the screening, start treatment potentially, or refer to a specialist. And you can see on the box on the right, what it seems like now is that if you're going to see a specialist or your loved one is, it can take maybe up to more than 2.5 years to get treatment started, beginning with the timing of scheduling that appointment with the primary care. And so during that time, if this is something like an Alzheimer's disease, the symptoms are going to progress. And that could be a significant progression that can occur over 2.5 years before getting into treatment. Here is an abbreviated list of the possible underlying causes of dementia or memory symptoms and cognitive change, with Alzheimer's disease being the most common cause. Usually, this is what we call multifactorial. So the way I describe it when I'm seeing a patient and family is that you're coming in for a tune-up, and I'm going to ask all sorts of questions. I'm going to be pretty nosy, do some tests to help figure out what the cause or causes are of the cognitive impairment that you're experiencing. And if it's more than I'd expect for your age, and then what are the next steps to figure out what can we do about this? So here I describe this as the first level of the memory evaluation process with the primary care provider or the specialist. Now, the specialist could be a neurologist, a geriatric psychiatrist, a geriatrician. Typically, you're going to need to start with the primary care, though, because especially most of our insurers require that PCP to refer for an indicated reason to a specialist for a memory evaluation. So first step, of course, asking all sorts of questions about what's been going on in what areas of thinking and how it's impacting that person's day-to-day life. The family input is crucial here, and often when we're seeing our primary care provider, if our symptoms are mild of memory loss, this is where, without having a family member there, as a memory specialist, it's pretty tough to know the real story. And I would always try to call and get a family member on the phone during the visit. And that would have to be someone close to them, like a spouse. Now, the patient sitting in front of me would sometimes be frustrated and say, it's none of their business. But if you have someone with cognitive impairment, if you're a provider and they're sitting in front of you and they have memory loss, we can't be certain of the accuracy of what they're saying. And so to really help them, it's important to get a trusted loved one in on the conversation. Now, of course, that point comes with the nuances of not overstepping the person's autonomy. There's ethical factors involved. And so it can be really challenging. And you can imagine a primary care provider doesn't have time necessarily to sort that all out. And they're just going to take the information they're getting. from that patient who's sitting in front of them and do the best they can with it. So if, I'm hoping that BrainLove, we can develop some resources to help family members who are in this space where their family member who has the cognitive impairment is resistant, and how to partner with them in the primary care to try to get that provider the information in a discreet and safe and respectful way to help them get the patient the care and help they need. And that's what we're going to talk about in the next talk next week, which is on getting a resistant family member to get a memory evaluation. Now, step 2, bedside cognitive testing. So this is in the clinic, usually a paper-based test. These are some of the common ones used. The MOCA, the MMSE, and the SLUMS are the acronyms. Now, some people try to practice these before they're taking them in the clinic, and maybe they're going to score better for that reason the day of, but that doesn't help, as you can imagine, us get an accurate assessment of what's going on with them and their thinking. So that's called practice effect. If someone scores higher because they just were at home and they did the test, and then when they come in the clinic, it's fresh on their mind. Otherwise, there's a number of other tests that could be done and questions that could be asked at the bedside. However, if someone is early on in their cognitive decline, say they have the very beginnings of Alzheimer's disease, but we don't know yet. But they're very early on and they're, say, well-educated, they're often going to score normally on these tests. These tests are pretty basic, and that could end up being very misleading. So if they score normally, say your family member scores normally on the MMSE, and you are very certain that there's been this progressive decline in their cognition over months to years, and saying their cognition is normal because of this test does not sit right with you, then that's where I will talk in a little bit about how important it is to advocate and get more information. And I'll give you what the next step should be. So we have done those bedside cognitive tests. Now moving on to step 3, physical exam and lab tests. And so physical exam encompasses also the neurologic exam. There's so many possible causes of memory loss, and many of them are not brain primary. They're not neurodegenerative diseases like Alzheimer's disease or Lewy body disease. So it's essential to do a physical exam to look for other causes and indicators, and even say things like blood pressure, blood glucose, and the neurologic exam can indicate things like, is there evidence of, say, the beginnings of Parkinson's disease or Parkinsonism, which could suggest Lewy body dementia, which is a topic for a whole other talk. But Parkinsonism would be things like tremor, stiffness, slowness of gait, slowness of thinking, slowness of talking. It's really slowness of everything. Like the person they haven't always been like this, but suddenly it's like they're walking in the mud, and even like the thinking and the coming up with the responses has slowed down. And then also things like the writing has gotten smaller. So a really astute primary care provider may pick up on some of these things if they're used to seeing older adults that have Parkinsonism. And then the lab tests are going to be a variety of things. So there's usually going to be a complete blood count, electrolytes, kidney function, thyroid function, vitamin deficiencies, including B12 and folate. Do they have persistent, poorly controlled diabetes? Things like that, which could cause cognitive change. So really comprehensive lab assessment for a variety of causes, including tailored to that specific person, and knowing issues that they have, checking their blood pressure, making sure that's not too low or too high persistently, because that can cause changes in thinking. And that's a brief summary of the physical exam, neurologic exam, and lab tests. Now, step 4 would be structural brain imaging. So say the primary care provider saw you or your loved one, asked all these questions, did this bedside testing, did the exam, and sent you for labs, blood tests. Now, hopefully they order brain imaging, so a brain scan. Now, when it comes to older adults who are having cognitive change, we must look at the brain because diseases like Alzheimer's disease are brain diseases. And so we need to look at the brain. An MRI is going to be preferred to a CAT scan. Still, people ask, including healthcare professionals, like, why do we need to get brain imaging? Well, there's important things we're looking for on the brain scan. And again, an MRI brain, typically we don't need to use contrast unless there's concern for potentially tumor, cancer, infection. Usually, if you're looking for those, it should add contrast. So with and without, it's called gadolinium when it comes to an MRI. But an MRI is going to give us a much clearer picture, especially if we're wanting to look for any changes due to things like Alzheimer's disease. What are we looking for with the imaging? We want to look for any surprise findings, such as a tumor, strokes, or brain bleeds. Now, I'm saying surprise findings because the person, I've examined them and they don't have any what we'd call focal neurologic findings to indicate that maybe they had a small stroke, and say they have, weakness on one side of their face and then their arm on that side. And sometimes that can happen and it's pretty subtle and it doesn't lead to the person going to the emergency department at the time of, but we pick up on it after. And then we're looking for atrophy or shrinkage in the brain. And in Alzheimer's disease, and in some other causes of cognitive impairment, we see shrinkage in the hippocampus, which if we look in that picture on the bottom on the right side, those little areas toward the bottom and on the inside, that's in the medial temporal lobes, the short-term memory center of the brain. That's where you're storing new information that was just provided to you or was just learned. And so that area is often the first to start atrophying or shrink in Alzheimer's disease. And so you can see here that brain tissue compared to the left side, which is the normal healthy brain, which is much plumper. The one on the right, the Alzheimer's brain, is not. It's a little more shriveled up. And then we have atrophy of the cortex in Alzheimer's disease, which you're going to see as the disease is progressing. And often, we wouldn't see this shrinkage until we're well into the mild dementia stage of Alzheimer's disease. So the cortex is the outer part of the brain, which controls all the higher thinking functions like language, visual spatial skills, executive function, which is like planning, multitasking, organizing, and vision. And so those are represented in different parts of the brain. And so those are the things we're looking for. And also cerebrovascular disease burden. And we call that white matter disease or white matter changes. And I'm telling you this because you may see this on you or your family member's report, brain MRI report, that maybe there's a mild or moderate amount of white matter changes. And when there gets to be a moderate degree or more, that could be a primary cause of cognitive impairment, which historically has been we'd call vascular dementia, although that term has become a bit confusing about what that actually means and what's really going on there. Now, a CAT scan, I just want to mention, I didn't put a picture of the CAT scan of the brain. Now, that's going to give us some information, but it's just not as crisp. It's not going to really help us quantify the degree of shrinkage the way the MRI does or the amount of cerebrovascular disease. And so if you're going to your healthcare provider, I would push for the MRI. So that's why we need to get that brain scan and the memory evaluation. Now, what can happen in terms of possible specialist referrals after you or your family member sees the primary care or the memory specialist? They may refer the patient to sleep medicine for things like maybe there were signs or symptoms that the person has untreated obstructive sleep apnea. That's a whole other big topic that is so fascinating and important. And we know that chronically untreated obstructive sleep apnea not only can cause cognitive impairment, it is a risk factor for future dementia. Now, a person may have active sleep where their family member says they're acting out their dreams and literally like punching and kicking them. I don't mean twitching or little movements. I'm talking like big movements, falling off the bed, injuring their bed partner, where the bed partner is like, yeah, I have had to sleep in another room, I put a pillow between us, things like that. So active sleep is suggestive of what we call REM, sleep behavior disorder. And that could be an indicator that there's Parkinson's or Parkinson's related changes happening in the brain. Not always, but that's another important reason. And that would lead to a person needing a sleep study. Now, a person may be referred to psychiatry or geriatric psychiatry if there's a big component of mood changes, such as depression, anxiety, irritability, agitation, or suggestions of psychosis, delusions, hallucinations. They may be referred for a formal driving evaluation, counseling or therapy, physical therapy, occupational therapy, and social service agencies at this point, even before there's a formal diagnosis clarified and causes of what's going on. To say you've done all this, then what happens next? Now, the second level, if it's not clear yet what's going on, this would be the next tier, next level of evaluation if it's clinically indicated. So some things that may occur. There may be a referral for a comprehensive neuropsychological evaluation. The way I describe that is, say the person's on their bedside cognitive assessment with the primary care, they scored normally, but yet they're still very concerned, or their family members are very concerned, or there are other features that suggest that there is something could be going on in the brain and it's not just normal aging. We'd refer them to a neuropsychologist for this. And it's a 3 to 4 hour battery of tests that cover all of those cognitive domains like memory, language, visual spatial skills, executive function, amongst others. And it gives a fine grained understanding of how the person's doing in these different areas. And then subsequently, is there a pattern of changes that suggests a certain cause or causes? And neuropsychologists typically provides a really beautiful comprehensive report and often will explain it to the patient and family in a way that they understand and can start acting on. Now, this isn't the last step. This isn't this isn't going to clinch the diagnosis because we need to do more steps or tests. But this can be very valuable if it's unclear what's going on. Then there may be an EEG ordered if there's suggestion of seizures, which usually these wouldn't be the kind of convulsive, obvious seizures that we think of, but more what we call complex partial seizures, where the person's like zoning out or doesn't seem there and they're going in and out. Then we have functional imaging. So you may have heard of an FDG PET. So that's another kind of CAT scan where a tracer is injected, and that's going to look for the glucose metabolism in the brain as a proxy for energy usage. And the reason that might be ordered is because if there's a thought that this could be Alzheimer's disease or frontotemporal disease or Lewy body disease, and it's not clear, those entities, those diseases show different patterns of energy usage in the brain, or decreased energy usage depending on the cause. So Alzheimer's disease shows decreased glucose metabolism in the temporal and parietal lobes typically. Frontotemporal lobar degeneration shows that frontotemporal hypometabolism or decreased metabolism, and then Lewy body disease shows parietal and occipital decreased metabolism of glucose. Moving on to a higher level of testing, that would be, and this is playing more of a role recently with the advent of new, more effective treatments for early symptomatic Alzheimer's disease, is testing for Alzheimer's disease biomarkers. And we now have multiple ways to do this. We have an amyloid PET scan, which again is the PET scan is a kind of CAT scan, but the amyloid PET is different than the FDG PET. The amyloid PET is specifically looking for those amyloid plaques, which we know are a primary pathologic hallmark of Alzheimer's disease and will be elevated in Alzheimer's disease. So the amyloid PET scan was I believe last year, or maybe the end of 2023, Medicare agreed to start paying for that, namely for people who might be eligible for these anti-amyloid treatments. So that seems to be covered by Medicare and other insurers once a year. It's an expensive test, otherwise out of pocket, it's multiple thousands of dollars. Another option that's less expensive, but maybe has some other downsides to it, would be cerebrospinal fluid testing, which would be through a lumbar puncture or a spinal tap. And so that's a relatively safe and well-tolerated procedure when done for this purpose, which is very controlled and calm and can be done in a clinic in an outpatient setting. A little fluid only is needed. And I have done many, many of these, and they usually go really well and pretty quick. So we send this fluid to a specialty lab to look for the amyloid levels and the tau levels, a certain type of tau, phosphorylated tau, which is specific for Alzheimer's disease, and something else called total tau, which is a non-specific marker of neurodegeneration. So this cerebrospinal fluid testing for Alzheimer's has been around since the mid-90s, yet it's not used as often, and it can be challenging to find a provider or someone who will do the lumbar puncture for this reason. And unfortunately, I think part of the reason for that is because it's not well reimbursed. In fact, there's been studies done that suggest that doing this test for this indication, such as looking for Alzheimer's disease, is actually clinics lose money because of the low amount that they get reimbursed. And this is unacceptable, but this is the reality. And I just think it's important that we all know, like, the situation that we're dealing with. Now, amyloid PET scan, I'll mention, while, the one main risk for that is you are getting a small load of radiation with any PET scan, but getting that specific tracer to look for the amyloid, that's not necessarily readily available. And it's really often mainly in big cities, and there might be some work for your provider to figure out where you can have that test done. Now, Alzheimer's blood biomarkers are a very hot topic now, and they're quite accurate for diagnosing Alzheimer's disease in a symptomatic population. They're not yet covered by insurance, and there's certainly more things we need to learn before these are ready to be released and approved and paid for by Medicare and other insurers. Now, from my understanding, I should mention, though, of course, it's not just, blood test isn't just a blood test. It's not just about getting the blood drawn. It's about, what do you do with that information? What does the provider do with the information, whether it's abnormal or normal? And depending on the patient's presentation, what are their symptoms, and what's available, and how do you act on that, and how do you counsel the patients and families? And so those are the questions that are really concerning, especially as a provider who sees these patients and knows it's not just an easy yes or no and walk out the door. Whereas those that are making these highly accurate blood tests are really excited to push them through for many reasons, to help people, but also because this is, theoretically will be a moneymaker. Then we have Alzheimer's genetic testing for the ApoE gene, specifically the ApoE4 gene is the increases genetic susceptibility to Alzheimer's disease somewhat during life. So that's a whole other conversation about whether Alzheimer's or what component is hereditary. Interestingly, ApoE testing is just recently getting covered by insurers only in the settings of if the patient is being considered for these new Alzheimer's treatments, these anti-amyloid monoclonal antibody treatments. Because if one is a carrier of ApoE4, and I'm hopefully not confusing you too much, but I think it's really important for anyone whose family member is going through this process to at least have a sense of this concept. So if they're a carrier of the 4, if they have 1 or 2 copies, especially if they have 2 copies, both copies are 4, they are at a higher risk of the main concerning side effects of this new class of drugs. And those concerning side effects are possible brain swelling, and brain microhemorrhages. Again, that's a big topic for another BrainLove community talk, hopefully in the near future. So I just mentioned this amyloid confirmation that a person has elevated amyloid, and then so indeed does have Alzheimer's disease, symptomatic Alzheimer's disease, is required if the patient is to be considered for these new drugs. All right, so if anyone has any questions, feel free to put. So some of the possible results you'll hear, maybe normal aging. You might hear the person has mild cognitive impairment. Maybe they have dementia, or maybe they have other causes. Or it could be they have mild cognitive impairment and other contributors or causes. If the person's diagnosed with mild cognitive impairment or dementia, why does it matter to know the cause or causes of that? So often, from what I have heard, and is the reality, people are told they have MCI or dementia, and that's kind of it. And that is not enough information to really know what to do with. So why is it important to know? So the disease course varies depending on what the cause is of the MCI, the underlying cause, the pathologic cause or causes. And then therefore there's variable impact on day-to-day life and function depending on what the cause is. There's different safety considerations that can come up over time as things evolve. We know there's certain treatments specifically for Alzheimer's disease that are only indicated for mild cognitive impairment or mild dementia stages of Alzheimer's disease. So if one is just diagnosed with MCI and then told to go on their way, then they don't know that whether or not they have MCI due to Alzheimer's disease. And then they will therefore likely not know about if they're a candidate for these treatments and be at least, discussed with them and their family. Similarly, access to specific medications and support, connect to community facing similar disease. So I'll shift to Lewy body disease. If any of you are familiar with that or have had family members, that can be very challenging. It can be very mysterious. This is what Robin Williams had. And often people go for years seeing different specialists and not knowing what's going on. It can impact cognition, but often the short-term memory isn't the most predominant feature like it is in Alzheimer's disease. It can be more that multitasking, planning, organizing. People with Lewy body disease can have Parkinsonism, so they may have the tremor, the gait slowing, stiffness, falls, and that could send the provider off in a different direction, looking for cause, like looking at their spine to see if there's a reason they're having falls. Then they often have neuropsychiatric symptoms, so that can send them to a different specialist, such as a psychiatrist who may or may not know about Lewy body disease to that degree. So when okay, your MCI is likely due to Lewy body disease, then you can connect to a Lewy body disease community, Lewy body disease association, for example, and get so much more information and so much earlier, which really does have an impact on the experience for everyone. And then you can have more, when you know the cause, you can have more open communication with your loved ones and planning ahead. Really, all of this supports one living the life that they want to live, given what they're facing and what's important to them. So say you hear that MCI is present. So mild cognitive impairment is vague. It just means more cognitive decline than expected for one's age, but still functioning independently. There's many possible causes of MCI. Alzheimer's disease is the most common cause, but Alzheimer's disease biomarkers, again, are needed to accurately diagnose that specific cause. Now, without biomarkers, without the Alzheimer's disease biomarkers, we learned in the IDEAS trial, which we were able to do amyloid PET scans on people with MCI, we learned that clinicians misdiagnose Alzheimer's disease half the time in people with MCI. So half the time we say it's due to Alzheimer's, they don't have elevated amyloid in their brain. They have something else. They have other things going on. So that additional workup needs to be done. And then Alzheimer's disease biomarkers have only recently become available and reimbursed. Now, half of those currently with MCI will never progress to dementia. And there are many reasons for this. And I think that this is a misnomer in many ways and leads people who are diagnosed with MCI to really latch on to this statistic. And I think what's going on here is that people have been historically, before we had Alzheimer's specific biomarkers, they're told they have MCI, and it's thought to due to Alzheimer's. They never know if they actually have the Alzheimer's changes in their brain, and it turns out they don't, so they don't progress to dementia because they actually have something else. They could have, say, untreated obstructive sleep apnea. They could have, other metabolic issues, other diseases going on, a variety of things. So this is a confusing concept, frankly. And so I say, don't stop at a diagnosis of mild cognitive impairment. Find out what the underlying cause is. And this is just a graph that we see the stages in Alzheimer's and related diseases. It's slowly over time progressing from silent changes to the mild cognitive impairment where the person's still functioning independently to the dementia stages. And that really is a slow, insidious process. Now, if you're told that you or your loved one has dementia, similarly, don't stop at dementia. Find out what is the stage, and we talked about this in the first talk, Alzheimer's versus dementia, mild, moderate, or severe, and then what is the underlying cause or causes. And this is just a breakdown of what mild, moderate, or severe means when it comes to dementia in terms of functional change. And I encourage you to ask the healthcare provider to be specific with this. But this really does help guide appropriate resources and care and support when you know the stage. And I had mentioned in the first talk, I showed that there's different categorization schemes, and we're moving towards, if you look at that, the FDA, the dark blue, trying to go towards stage 1 through 6, especially so we can all speak the same language when it comes to Alzheimer's disease dementia. So what if you don't have the answers you want or need after you've gone through this whole engagement with the healthcare system to get the memory evaluation for you and your family members? We know there are many barriers to getting the information you need. And despite all of us healthcare professionals really wanting to help, it's really challenging to provide a comprehensive level of diagnosis and treatment and support for people facing these diseases. And this is just a list of some of those reasons. So I encourage you, if you're not feeling like your healthcare provider is really listening to you and your concerns, to get a second opinion, to ask for a referral. Ideally, you're going to see a memory specialist. Usually it's a neurologist or geriatric psychiatrist or a geriatrician, but a general neurologist who seems knowledgeable about and interested in memory loss and dementia could be helpful. Alzheimer's Association can be helpful. They do have a 24/7 hotline. And then I have just listed some other things that may be available in different areas of the country, such as there's an area agency on aging all over, different states have these. There are caregiver coalitions. There are geriatric care managers that can be helpful in directing to the right resources and support. Those are often pay out of pocket. However, what I've seen, again, when I've seen people that are struggling for years, being frustrated that they're not getting the answers that they need, and not only are they frustrated, but there has been challenges because of the person's symptoms, trying to piecemeal getting the support they need. It can be, frankly, traumatizing over that amount of time. And so it may be worth investing some money early on in someone like this, like a geriatric care manager. But I would say it's really important to try to get a recommendation from a friend or someone you trust, because of course it's hard to know who's really good in these areas. So, and then please always connect with me if you have questions for yourself or your loved ones. Email me. Happy to try to help you navigate the system, and hopefully this is improving. There are many services, agencies, individuals that do really help, and it's just a matter of how can you or your loved one get to them when you need it is really the key. So next steps after a diagnosis. So say you've gotten the diagnosis, say you got the full court press, you have, or your person has Alzheimer's biomarkers, say they have mild cognitive impairment or dementia. I'd say mindset work is the most important thing that I've come to, because it can be demoralizing and dehumanizing for everyone involved, because of the way we view these diseases. And so it's really a matter of pushing back on that narrative, and that is difficult, but it can be done. And I have seen people do really well who aren't willing to accept that their life is over, because it's not. And many people have these diseases for many years and they live very full lives. And so it's important not to jump to the end and feel like you're already there. Avoid isolating. Because of the stigma and some shame, sometimes people or family members keep this really hush hush. But at the end of the day, that often leads to them not getting the support and services and connection that could be really helpful if they were open about what was going on. The 7 million people in the US have dementia, so it's likely that you speaking up about this, that you or your family members experiencing, other people around you will then also say they're also experiencing this. Self-care and wellness is important for everyone involved. Right away, figure out, okay, this is really a marathon, and how are you going to adapt and adjust your life and schedule so that you can continue to infuse it with those things that make you feel good? And that could be a variety of things, and you may need to adapt how you're doing them, but it's so important to keep those going. Build your team, collaborate with family, friends, medical professionals, and community. Spread the net. People really do want to help. And when family and friends offer to help, definitely take it and don't wait till you're feeling overwhelmed and burnt out. Open communication with loved ones is huge. And from what I've seen, the families that can be more open and honest and transparent with each other about what's going on, the good and the bad, they do better ultimately. And then advocacy. We need to advocate all along to make sure we're getting the most precise diagnosis and support. We'll probably need to do as a family, if you're a loved one of someone going through this cognitive decline, it is going to be a lot of legwork, especially at first, to find the right resources and connections that can be helpful, but it's worth doing that and advocating for yourself. And just getting through that and then finding that can be very empowering. That you'd like me to present on, or people that I can bring on as guests, let me know. I'm going to start bringing some interesting guests on. That should be fun and illuminating. Great. Well, have a great day, everyone. See you next time.